Hello, everyone. Welcome to the American Congress of Rehabilitation Medicine Rehabilitation Treatment Specification Networking Group's inaugural Users Forum. As the group's community chair and secretary of the group, I thank you for attending this meeting. I'm sure you're having a busy and wonderful summer. But we're glad to convene and talk more about the Rehabilitation Treatment Specification System, also known affectionately as RTSS. And we'd like to go over some housekeeping things first. First of all, this webinar is being recorded, so I ask all attendees to mute yourselves and turn off your cameras if you're not speaking. And secondly, if you have questions throughout the discussion, you can go ahead and type them into the chat box, and we will address as many as possible. And to kick off our webinar, I will turn it over to Dr. Leanna Katz, who will introduce herself.
Thank you, Susan, and welcome everyone. We are very glad to have you here for our webinar on the Rehabilitation Treatment Specification System, also known as the RTSS, and clinical reasoning. So my name is Leanna Katz, and I'm an occupational therapist, and I am out of Boston University in Boston, Massachusetts. I am joined today by my wonderful colleagues and interdisciplinary team, who I will pass along to allow them to introduce themselves. Sue, you want to begin?
Sure. Hi, everybody. Welcome. I'm Susan Pasoli. I am a professor of occupational therapy at the MGH Institute of Health Professions, also in Boston. And I look forward to your comments and sharing our experience with you all.
Hey everyone, nice to meet you. I'm Jamie Gibson. I'm a physical therapist from London. I work for Guy's and St Thomas's NHS Foundation Trust, and I'm also a fellow with Health Education England.
Hello everyone, I'm Sue Ann Sisto. I'm a physical therapist and a professor and chair of the Department of Rehabilitation Science at the University of Buffalo. I'm very excited to have you join us today to share our ideas about the RTSS.
And I'm Lynn Turkstra. I'm a professor and the Assistant Dean for Speech Language Pathology at McMaster University in Ontario, Canada. And like Sue Ann, I'm really glad to see all of you here.
Excellent, thank you all. So for today's webinar, our format is a little bit different than our traditional webinars in the past, in that it's a Q&A format. So we will be having this multidisciplinary panel discussion, but we also invite you to participate in that discussion, as we'll be posing questions to our audience members to respond, but either by unmuting yourself and responding verbally, or please feel free to add in your comments in the chat. So to kick it off, we'd like to hear from you. First, if you don't mind sharing your discipline and perhaps your work setting and how you heard about the RTSS. And we'll give you a moment to add your response in the chat. Thank you all. Give it another minute to share. Great. I recognize some names, so welcome back, and others, it's nice to have you here. And great. Thank you all for participating. So we can go ahead. Again, just some meeting tips similar to what Susan shared. Please mute yourself if you are not speaking. And then if you do want to contribute, please unmute yourself. We encourage audience participation. So to go over our learning targets, what formerly known as objectives, Today's target of our presentation of our webinar is to increase your propensity to use the RTSS in your respective work settings. So our ingredients include providing accessible examples from OT, PT, and speech clinicians and academicians, identifying contextual factors that support RTSS adoption and development of clinical reasoning, and lastly, asking you to generate a plan for one RTSS activity that you can use in your own instructional context. So let's begin. So our first question that I'm going to pose to our panelists is, how and for what purpose have you used the RTSS in your respective settings?
Okay, Leanna, I'd like to begin. We've actually begun to integrate the RTSS across courses in our entry-level OTD program, including our theory-based foundations course and practice courses that are focused on physical rehabilitation and pediatric interventions. We're also using the RTSS framework when educating students about the link between treatment theories and occupational therapy and clinical reasoning, and during active learning case-based scenarios. During my stroke rehab elective last spring, I used the RTSS framework to guide students' review of the literature on stroke interventions and their applications to clinical practice. Our post-professional OTD program has used RTSS concepts to guide the planning of their student innovations projects.
So I'd like to follow up with Susan's comments by indicating how I started at the University at Buffalo. I started with presentations on the basics of RTSS, really to all the faculty in the DPT and OT programs. But then I followed it up with a second review to faculty who returned and who I then identified them as key RTSS ambassadors. So then we reviewed the RTSS practice cases, which are an available resource, and expanded those to specify the cases in their own courses. I've begun in a similar way in my own DPT evidence-based practice courses, where I began integrating the RTSS when reviewing evidence of physical therapy interventions. So I teach this in the form of a flipped classroom, which really does require active learning. The group work facilitates the development of clinical reasoning as they start to share their clinical experiences with one another as they try to specify cases. And then I plan to introduce our students to some definitions of clinical reasoning so they understand the concept of clinical reasoning. And I use these little exit tickets at the end of each class, a little piece of paper that more or less indicates a question about the class. And after introducing the RTSS, they really seem very excited about this content and express that they wanted more.
And I will go next. So in the McMaster SLP program, the students learn the RTSS right from the beginning of their program as a framework, the way they learn the ICF framework. And then we build on that throughout their program in clinic and actually across all their classes. For our graduate students in rehabilitation science, the RTSS has been used for student activities like systematic or scoping reviews to identify ingredients and targets across studies. And for my own research, we use the RTSS in clinical trials. And so the purpose of that for students, I'll say, since we're here to talk about academics, is we want them to have the RTSS as another tool in their critical reasoning and clinical reasoning toolkit.
Okay, I'll finish off. So at Guy's and St. Thomas's over the last 18 months, we've had a clinical focus with implementing the RTSS into the clinical practice of inpatient rehabilitation physical therapists. And of course, we have an interest in improving the measurability and the reproducibility of treatment through the properties of the RTSS. But to begin with, we've had a real focus on clinical reasoning. we feel through the questions that are posed from the RTSS, i.e. what are you directly trying to change with treatment? How will you infer that change? How will volition influence your treatment design? And you know, in the middle of that, how does your treatment achieve the target? These are all questions that naturally lend themselves to the clinical reasoning process of treatment planning. So we've adopted that language of the RTSS and attempted to implement it into our treatment discussion forums, and particularly our case discussions. We've also used the RTSS to start mapping out service interventions. An example that we've published is our preoperative spinal education program. And that's really, you know, us looking at what do we want to achieve with these new services? What changes do we think we can impart? And are our current treatments appropriate for these?
Thank you all. And now we pose the question to our audience members. How have you used the RTSS in your respective settings, or how have you thought about using the RTSS in your settings? So again, feel free to use the chat function or unmute yourself to participate. And we'll give it a moment for people to respond.
And we'll do this after each question, so just be prepared when it comes around again.
Great. Assignments. Yes, please.
Yes, I'm Jewel, assistant professor in OT, and I'm trying to use the RTSS to describe standard occupational therapy for children on the autism spectrum, and to identify what OT treatment components look like and what are the active ingredients across frameworks.
That's fantastic. Thank you for sharing, Jewel. It's nice to see that there's a mix between academic use, research use, and clinical use. Fantastic.
It's great to see all these assignments.
And this is to help all of our participants see how it's being utilized. So you have the examples from our panelists, but also from our audience members as well. So please read through the chat if you have a moment. Thank you for those who responded. Fantastic. Any others who want to share by unmuting? Really fantastic examples. Thanks all for sharing. All right, let's move on to our next question for our panelists. Where and how did you start with Rtss implementation?
Okay, so I'll get us started on this question. As I mentioned, I started by reviewing basic information to all faculty, but I really tried to emphasize sort of the conceptual reasons for using it as well, by asking questions about key terminology such as targets, ingredients, and mechanisms of action, trying to keep it as simple as possible initially, because it is a different language to begin to learn and understand the value of it, so that they could begin to see the impact that it could have on students for clinical reasoning. And then ask them to prepare cases that they must include in their treatments that they teach in their courses. And then we're in the process of reviewing these cases of their treatments that they're planning to teach in their courses, and just continue to brainstorm with them to identify best practices for implementation to other faculty as well.
In our OTD curriculum, I started with my own course that introduced our second semester OTD students to biomechanical and rehabilitation frames of reference in OT. During the spring semester this past year, I held a series of Rtss implementation meetings with 4 interested faculty and students to brainstorm ways to integrate and scaffold the Rtss throughout a number of courses in our OTD curriculum. We found it was really important to begin by reviewing those key concepts similar to what Leanna has talked about, and discussing similarities and differences in occupational therapy versus Rtss language, especially around the concept of mechanisms of action.
Like Sue, I started with 1 instructor and 1 course. Lots and lots of time in services, and we gradually infused it across the curriculum. We also presented it, as I said, to students as a core framework so that it was just a given as part of the program.
So I feel like a natural place to start for this was, you know, we're lucky that we have an environment that's supportive of critical thinking. And my colleague, Dr. Gareth Jones, has been following this work for a long period of time now. And alongside of this, the black box of rehabilitation is a very real thing clinically here. So we went out looking for grants and essentially posed how the black box manifests itself clinically, locally, and how we felt the Rtss is quite a nice countermeasure for that and something to try out. And given the Rtss being new, it's always going to be an education as a vehicle for its adoption, which was fun because neither myself or Gareth are well versed in pedagogy. So we're shopping around local HEIs. We have an educational development lead and also myself taking up a fellowship to come up with a teaching program. But I guess our clinical consideration was, you know, our clinicians are always working in ever tightening time constraints. So it was finding a natural opportunity to piggyback or integrate the Rtss within. And that's where weekly case-based discussions where clinicians had protected time to talk about the backgrounds of patients and then think about what we're going to do as a physical therapist. That presented a natural opportunity for us to piggyback on.
Thank you again. And similar question posed now to our audience members. How did you start with Rtss implementation? I saw in the comments, there were some people who mentioned that they started with learning specific terminology and starting with an example with ingredients and targets. So again, feel free to unmute yourself if you'd like to share further. Having a champion is a common theme that we've heard, and I'm seeing that as well.
Also getting the buy-in from everybody.
Great. Would anyone like to unmute and share? Love an active chat. So this is fantastic. Great. Starting as one, that's a common theme. Wonderful.
I'll talk.
Please.
Yeah, my name's Matt Getty. For those of you who don't know me, I'm Texas Tech Health Sciences Center, and we really got started with my program director. I was on her dissertation committee, and in her literature, she found the Rtss, and so we started talking about it, her and I, and then as the whole faculty. And we kind of got lucky in one way. We were moving from the MOT to the OTD for our entry-level students. So we really had a chance to put the Rtss in and throughout our curriculum in places where we thought it was would make sense. And so we've tried to introduce it early in the curriculum in a sort of intro to what is OT kind of class, and then start to build on that with students sort of learning the terms and understanding how the flow goes. And then as they get into sort of the end of their first year, into their second year, we start to have them in intervention classes where we can really put the RTSS to work for them. And so that's kind of what we've done and how we got started. And we tried to do our best to put it all throughout the curriculum where it makes sense. And I think that's a real way for the students to, understand the importance of it and see that we're kind of committed to it. And so if you're just beginning from that perspective, that I think that's where sometimes we have problems is getting the full commitment to it. It seems like a good idea to some people, whether you're a clinician or a teaching situation, either way. But if you kind of make it a piece of what you do all the time, we're having some success with the students picking up on it and understanding why it could be a powerful tool, I guess. And got a couple of my colleagues, Cindy and Megan, if you guys have anything to comment or add to that, feel free.
I don't know that I really have anything to add, Matt, but I would agree with that. And I mean, I would say kind of that Lone Ranger, Matt and Sandra kind of came in as the Lone Rangers, but I think it's a really great thing that we all had different levels of comfort with it, but we're all willing to learn more about it and try and incorporate it.
I would say too, you can see a difference in our students. I think the first year they didn't get it. And I think it's because the faculty were still learning too. And I definitely have seen an improvement this second year. And I just anticipate that that's going to grow every year. So it's tough in the beginning, but I would say stick with it.
All fantastic advice and great examples. Thank you for sharing that. Does anyone else want to unmute to share?
I would like to say that as one of their students, I was in the post-professional doctorate program, and I found it very fascinating the way that the terminology kind of linked itself. Like Dr. Getty said, they introduced it to us in the very first semester, but we were using it all the way through our capstone. And I found it very useful and practical, and something that I'm hoping to continue to incorporate more and more.
That's exactly what we want to hear, that you learn about it, you incorporate it, and then you take it with you after you graduate and go transition from the school setting to your clinical work or research. That's fantastic. Thank you. Any other comments before we move on to our next question? All right. Feel free to interrupt me if I'm going too quickly, but we'll move on to our next question to our panelists. What ingredients do you have in place to sustain your practices?
So I will start with that. Sorry, I'm just seeing Matt has posted about starting small and then sort of spreading it throughout the curriculum. And one note about Matt's that is something I could have mentioned before is that we also had the opportunity building a new program to incorporate the RTSS. So I think it's a little bit more challenging when you have an existing structure to do something new. So like Matt's talking about, you have an opportunity from moving from the master's to the OTD that gives you a chance to really have big changes in the curriculum. So in terms of ingredients to sustain practices, I changed this wording because we do use the RTSS terminology everywhere. So we had measures, but we thought a lot about the ingredients that are necessary for someone to change habits, which is what we want. So we want the RTSS to be a habit. So we had a lot of ingredients that were about a knowledge target. So students doing some reading and in fact, their first semester students did a comparison of the RTSS and the ICF about, how they address different aspects of rehabilitation planning. And then we just provided a lot of opportunities for practice and feedback. One thing that we had to spend, and by we, I mean Justine Hamilton, who's our Director of Clinical Education, spent a lot of time mapping the RTSS terminology onto terms that students would come across in their general clinical training. So I think that was another conscious selection of ingredients to help support implementation and maintenance across the program.
Really good points. For me, to sustain this introduction at UB is really to continue to have these monthly meetings and brainstorming that are workable for faculty, and begin to think about how to integrate it across the entire curriculum. You know, and as Lynn mentioned, how difficult that can be if you're in an existing program, but not impossible. So that's where I'm at, and in the structure of our existing programs, to really try to implement it through the faculty knowing the importance of it and having enough practice to specify treatments so that as they introduce it in their classes, they're more comfortable, even willing to go to a class with a faculty member who is introducing it for the first time in their class to kind of be a backup if questions arise from students. And I'm really starting with the first year PT and OT students and their respective faculty, really just one course at a time, and then building into the second and third year students. And in our programs, those are usually the students that have more clinical experience, and they're the ones that tends to resonate a little bit more with them because they can pull from their clinical experiences to try to specify treatments. And I also plan to just introduce literature on clinical reasoning to faculty and students, just to bolster the value of the RTSS framework.
I think we're all going to have similar ideas that we're sharing today in terms of sustaining practices and thinking about what those key ingredients are. You know, for me at the IHP, it's really a work in progress. You know, I think that faculty education and mentoring, as Sue-Ann was talking about, are just key. As are, you know, brainstorming ways that the RTSS can be used as a tool to facilitate that clinical reasoning and to really make it explicit across courses that address a variety of client conditions and needs. During our regular meetings that we've had with OTD faculty champions, we've brainstormed ways in which we could integrate RTSS concepts with existing course content. And some of our discussions have focused, similar to Sue-Ann, in terms of how we might scaffold instruction and use of the RTSS, both within a course and then throughout the OTD program. And I think it's the scaffolding that will help us to sustain and develop the use of the RTSS in our program over time.
From a clinical perspective, here we had a pretty simple school of thought based around one question really, and that was, what opportunities are there for the RTSS to appear in the social forum? And we are pretty flexible with our clinical teams within the department because all of them work slightly different. And that's been a benefit really, because we've produced several different ways for this to appear, such as our caseload discussions, as I've mentioned, service development projects, junior projects, publications, senior teaching programs, etc. But a key thing that feeds into the social forum, and I think is key for the clinical sustenance of the RTSS, is having a mechanism for it to appear in documentation. Fortunately, it feeds into what Lynn was saying about having new opportunities. We've got a new electronic medical record system coming in. So we see that as an opportunity to think about, okay, how can we shape that to integrate the RTSS within.
All right, again, question posed to audience. What ingredients do you have in place to sustain your practices if you have already begun to adopt the RTSS into any educational materials?
I just want to comment that I don't really have very many ingredients, and I find it really useful to hear from people who have been able to infuse it throughout a curriculum or widely throughout a curriculum, because I'm not aware of any other faculty who use this approach in my department. And now that I know a bit more about it, I have planned to do a pro-seminar presentation to introduce it. And I guess I would call that a future ingredient that I'm hoping to implement. But I have found, like others have commented, that over the years, student buy-in has increased tremendously as they become used to hearing about evidence-based practice. And I teach evidence-based practice as well as the aphasia course. So far, they're only hearing about this stuff from me, but I want to spread it more widely and see how other people's vocabulary maps onto the RTSS. I think it'd be important.
Jean, I put some ingredients in the chat just for fun.
And I think it's really nice for students to hear it from multiple courses. So they're not, associating you as an instructor as the only champion, if you will, or the only person, with that expertise. So, getting it introduced to a few courses, the students begin to realize, hey, this is the real deal here, and we have to start to adopt it with our reasoning skills.
Jamie, I should have asked you this before. What exactly is the social forum?
Yeah, so the RTSS is a defined language, right? And therefore, we sort of think if it's to live, it's got to be used socially, right? So wherever there's means for that language to be presented socially, whether that is one-to-one in a caseload review, whether that is you seeing someone else use the language in documentation. Yeah, I guess it's a process of accumulation of just seeing the language socially used by others.
Thanks.
Great points. And there's some really nice examples of ingredients in the chat for those who have implemented and adopted the RTSS into their practices. Does anyone else want to share by unmuting? All right. Moving right along. Our next question. My personal favorite question, where we learn the most. What challenges have you faced when implementing the RTSS, and how have you overcome or faced those challenges, panelists?
All right, nice. I'm kicking off on this one. So in our very preliminary efforts of teaching the RTSS, we quickly came across two challenges. At that point, we taught all clinicians of all grading at the same point, and we didn't teach them how to specifically use the RTSS in documentation. That may seem stupid, probably feeds into how well versed I'm in pedagogy, but our idea was to see what would be the natural emergence of this, and that created, like I said, two challenges. Firstly, by not supporting senior staff, we effectively limited their confidence to support junior staffs. And here locally, in terms of structure, our seniors are very key in driving the culture, right? So if we're not supporting them to be confident with the language, then the language isn't going to live in their own cultures. So as a countermeasure to that, we've reshaped our teaching designs, our program so far, whereby we meet the senior staff first, we provide them with learning resources and the opportunity to discuss. And we're also in a wider dissemination phase now where we're teaching the whole of the senior rehabilitation department before. The other aspect that I mentioned is documentation. There's probably two immediate issues that arise. Firstly, how to do it. And secondly, it takes time. It's a new skill, you've got to practice it. And obviously clinicians don't have all the time in the world. We can quickly countermeasure that by doing writing workshops. We produce documents on how to introduce into your documentation. And also hopefully with a new electronic medical record system that should help as well. But I also think there's sort of a deeper cultural issue here locally. It's great that the RTSS brings around transparency in terms of what you're doing with your treatment and your reasons underlying it. But that's new. That's very different to what we do here locally. So in a sense, that builds a sense of vulnerability to our clinicians as they expose their clinical reasoning and their treatment planning. We've done some quick things in terms of we have direct lines to chat through note attempts before submitting them. But I think that's probably a bigger issue and actually something just to respect and think over time as we support the adoption of RTSS. We got to recognize that actually it's quite a big cultural shift from what we're doing now clinically in documentation.
Yeah, I think that's really an important point, Jamie, is that cultural shift also in academia and trying to get individuals to buy into the concept of the RTSS. And some of that comes from just understanding the basic concepts of what it is and why it's important. And I found that with each meeting, sort of taking a moment to review some of the language, review some of the comments that were discussed last time. If someone said, I didn't really understand, what is volition and how do I incorporate that in my specification? So just a review of remember what targets are and ingredients are. And I found the more repetition, the more people were really getting it and thinking about ways they could introduce it to students within their courses. And that drew greater value to the RTSS just by building the confidence of understanding the terminology and the value of it. And then one kind of a interesting challenge was that when I was inviting faculty to bring their cases to our meetings, I realized this was that they had the cases prepared, but the cases were cases that they wanted the students to solve in their class, and they didn't come with specified cases. So we're in the process of expanding that work so that they come to our meetings with specified cases so we can actually brainstorm through those together. And then just a unique characteristic of academia is just that and many of you may have the similar situation where faculty are not on a 12-month contract, for example, and so there's less progress over the summer. And so what I've decided to do is use that time to just connect via email or other means to those RTSS faculty ambassadors to stay in touch and establish a plan to go forward for each of the fall and spring semesters.
That's great. I think that one of the biggest challenges that we had in our OTD program was really establishing a common understanding among faculty when attempting to instruct students and implement the RTSS concepts in both our entry level and our post-professional MTD programs. I learned the importance of developing and agreeing upon a consistent approach when you're using the RTSS to facilitate clinical reasoning across courses, because that we found was a real challenge this last semester that I think led to some of the things that Megan had talked about in terms of student confusion and sort of getting it after a while, and that repetition and consistency I think is really important. I also found that identifying ways to scaffold faculty instruction and use of the RTSS concepts, especially getting around or talking about mechanisms of action, has been another challenge. And I've started to face these challenges through those regular meetings with our champions, but also by creating an RTSS table that I'm hoping that we're going to use moving forward across courses. And I've also begun to use Bloom's taxonomy to try to fit Bloom's taxonomy and coordinate it with the RTSS to actually help us to scaffold the learning and application of the RTSS, both within and across courses. I think that these steps are going to be useful in moving our implementation of the RTSS forward, but it's a gradual process. And I think that that's one of the things that having that humility and the fact that we are learning how to do this best all together is an important framework to come from.
In addition to everything everyone said, which I agree with, overall, I think our biggest challenges are just a limited time and not a lot of resources for people at the entry level. So the manual in which at least 3 of us on this call were involved, it's not very user-friendly for someone who doesn't really know it. So it's more like a dictionary, a place that you can look things up when you already have a general sense. So I think not having ready access to a lot of practice healthcare problems and, just activities that people can do has really been a bit of a challenge for us. And as others have mentioned, when you only have one person who's the champion, it's really a lot of work to push that forward.
There is a question in the chat for Sue about Bloom's taxonomy, about if you've published the integration of RTSS with Bloom's.
Yes, and I was just starting to type the response back to you, Jean. No, I haven't published that yet. It was something that I developed with one of my capstone students this past semester, and really just took the RTS, I'm happy to share, but took the RTSS framework and Bloom's taxonomy and looking at different types of knowledge and different sort of progression of knowledge through the taxonomy, and thinking about ways in which we could scaffold both the way in which we're asking questions and how we're introducing the RTSS concepts to help to facilitate learning and understanding before we get to that application phase. So it's another work in process, but I'm very happy to share if you want to reach out to me.
How about for our audience participants? What challenges have you faced when adopting RTSS? Again, as always, please feel free to share in the chat or unmute yourselves. Give everyone a minute to respond.
I just want
Starting. Yes, go ahead. Sorry, please.
I didn't introduce myself earlier. I'm Susan Lynn, and I'm an occupational therapist. And I wanted to echo Lynn Turkstra's comments about how the manual is not super user-friendly, and how I had wished that we had some like workbooks, like beginner level, intermediate level, and advanced level for using the RTSS. And so on that note, I just wanted to share with everybody that if you're interested in trying to get RTSS out there and more user-friendly, there's a group of us in the RTS networking group that are working on creating products for curriculum. Also, a manual revision committee is meeting, and we are trying to come up with better ways of communicating the content. And so all sorts of ideas are welcome. And if you have any questions or interest, you can certainly message Leanna or me or any of the presenters.
Yes, thank you, Susan. And we'll share our emails at the end of our presentation. I'm seeing a lot of themes in terms of lack of resources and also the translating and interpreting the manual. And the distribution about the manual. I don't know the answer about that.
I can add to that, Leanna, if that's helpful.
Please.
So, hi, everybody. I'm Jean Zanka. I'm the chair of the Rehabilitation Treatment Specification Networking Group presently, and so grateful to this team for organizing tonight's meeting. The idea behind the not distribute of the manual was that we wanted to know who is downloading it so that we could evaluate its reach within the field and also be able to reach out to those people later on with updates and opportunities like being able to participate in meetings like that tonight. So that's sort of the reasoning behind the not distributing. And I welcome others who are using it in their curricula to comment on how they've managed that issue.
We actually don't share it with students because it's so overwhelming. So it hasn't been an issue. It's easier for us to have control over the amount of information students get. So we certainly take bits and pieces of the information from the manual, but they know that if they, in their future, they may choose to download it.
Yeah, we do the same. We give them the link on the ACRM website to download the manual themselves, and I don't share it with them in class and explain that they're going to get things in doses so that they don't get overwhelmed with the manual.
Yeah, and I've done the same thing as Sue Ann, but only really with my capstone students who had specific projects they were doing regarding the RTSS. If they went to the website, they used the link. Otherwise, I have been pulling out information and sharing it and scaffolding it through the courses that I've been teaching.
I would also add to that applies to teaching faculty and colleagues. So starting with a presentation and limiting the amount of information that you're giving them initially. So that scaffolded learning is really important. Any other comments or notes about challenges that people have faced? As you share the RTSS in small doses, what do you present first and how did you decide on that content?
That is a great question, Jean. And as you know, I have spent a lot of time on this, like small doses. So of our RTSS group, I am the least ambitious member. And so I am happy if students know target versus aim, if they know there's 3 groups of targets, and if they have the idea of ingredients and they understand volition ingredients. So for us, because speech language pathology is, I mean, certainly, and I know there are some of you on the call who do swallowing, but for a lot of SLP, it's really habit, skills, and representation targets. And so mechanisms of action has been a rabbit hole, as Jean will know, because we talked about this at length in the group. So I think when Sue's talking about the mechanism of action being one of the most difficult parts, we just don't deal with that. So I think that sort of simplified things to say, we're just be thinking about your treatment. You know, is there consistency between your targets, your ingredients, your outcome measure? And so very modest ambitions. I think that's the small dose. What's going to get the biggest bang for the buck in terms of student critical thinking?
Can I just second Lynn's comment about that? I use it in the clinic for a fellowship, and we just try to get people to look, are these ingredients really going to change the target? And have them be more conscious of representation targets in education versus habit and skills targets, and how those ingredients need to match up. And sometimes I think that those are enough to bring about a type of thinking that will help them evaluate across treatments, which is kind of what we're looking for. So we have reduced our goals as well, because we've got to deal with a demanding clinic that's got a, goals and documentation timelines that we can't change. So we don't want people translating and trying to spend all their time translating. We want them to just get those ideas.
Just to follow up on that, I'm sorry, Sue. I'll say quickly, the other thing that we did for our clinical trials is make a cheat sheet of ingredients. So because there's such wonderful inventories of ingredients from health psychology, volition ingredients, I mean, we created these cheat sheets for clinicians that had even specific wording for volition ingredients, and then just some good ingredients for skill and habit targets and representation targets, because it's sort of, that's a way to for you to feel like it was a bit more manageable.
I did a lecture in our first semester foundations course yesterday, actually. And what I focused on introducing the RTSS, kind of giving an overview of everything, using a real life example of making a mix of brownies and thinking about what the target ingredients are in that and what the potential mechanism of action is. And I also found a Prezi video that talks about, what those mechanisms are in terms of chemical changes, just to relate it to real life, to something that the students can understand to begin with. And I think the one of the things that I'm trying to focus on within our program is to help the students with their clinical reasoning, that not just to put those OT theories that they're learning in a silo, but to take those theories and say, well, this is what is guiding my thinking about why I'm selecting these ingredients. And so trying to get them to relate these theories to that target ingredient piece is really the way that I'm going after the clinical reasoning that goes a little bit, it's a different, slightly different approach than just identifying the mechanism of action, but it's right there. And I think it's trying to integrate OT speak and language that is understandable to them.
We got time for me to add one quick thing more. I was going to say, from a mechanism of action perspective, for those clinicians that have picked it up well, or at a more advanced level with this, I think there's a real cool function within physical therapy that actually has allowed us to stop it being a taboo subject to talk about those treatments that either we don't really know how they work, or actually for a long time we've just been performing treatments dogmatically and not really been thinking about, okay, what does the evidence actually say around the treatment theory for that, which is a great function of it. And I think also when a clinician does get advanced with it, and they get to a point where they start to understand the framework, and this is where the model starts forming, for those groups where the mechanism of action is fixed, you start getting a thought process of, cool, I've got a target here, it's in that group, this is a mechanism of action, and okay, these are some common ingredients that cut through those groups. So we have had examples, like I said, I think it is key when there's a good understanding of this a bit further down the line, that actually the mechanism of action supports the actual thinking process from target to ingredients.
Thank you all. Big theme is target and ingredients is a good place to start for many. Really quickly, we have 5 minutes left. We're going to wrap up with our last question for our panelists. What are your goals, aims for using the RTSS in the future? And for those of you who want to also answer this in the chat, please feel free to answer what your aims are for using the RTSS.
So I'll get us started. My first goal really is to continue to work with this great networking group to try to create materials that are user-friendly. So starting out with, again, beginner, intermediate, advanced, that was just mentioned, and really try to work to get these resources out to people that are usable. I teach evidence-based practice, so we always talk about mechanism of action because they have to try to find the rationale in the literature, but really trying to make the materials usable is our goal on this networking group, and just continue to work and keep the momentum with regular meetings. And lastly, I would like to build on this in the second and third year courses. So thinking of the first year as beginning, second year intermediate, and third year advanced. But I also would like to conduct some research studies to examine those students who feel strongly about the RTSS or had not been exposed to the RTSS, and compare, their ability for clinical reasoning once they're out in clinical practice, using some standardized clinical reasoning questionnaires and maybe some face valid open-ended questions.
Yeah, those are great ideas, Sue-Ann. My goal is really to graduate entry-level OTD students with an improved ability to think on their feet and to provide a rationale for why and how they expect their interventions to work using the RTSS framework. I'd love to see them better able to integrate research evidence into clinical practice, and for our more experienced faculty and clinical instructors to use the RTSS to explicitly describe their professional reasoning and why they chose their ingredients for a particular target. Ultimately, though, I think I'd really like to roll the RTSS out to other programs here at the Institute of Health Professions, including physical therapy, speech language pathology, nursing, and we have a PhD in rehabilitation science program that we've dabbled a little bit in, and so I'd love to roll it out more there as well.
I'd like to have everybody use it automatically. And I'd like the students to use it automatically in their clinical reasoning, clinicians to be thinking about what the heck they're actually trying to get, what functional change they're trying to achieve in therapy, and for researchers to specify their treatments better so we can actually use things that are published instead of just trying to figure out what the heck the researchers were doing for their treatment. I love Daniel's point. I just want to say here specifically about assistive technology, because I think that's a place where it's just a beautiful thing to see a well-specified intervention. And we haven't talked much as a committee about enablement theory. I mean, we've talked about how this isn't enablement theory, but I think that's a great point as well.
Cool. Last question, last answer to it, undeserved but greatly appreciated. Echoing everyone else, this to be the language that communicates treatment theory by our clinicians. I think we're really keen to get to a point where this is at a suitable level of fidelity that we can start looking at what effect it has on our routine clinical outcomes in the future as well.
Oh, you're muted,
Leanna,
Leanna.
you're muted.
Made it through the whole time. Thank you. Quick summary. Thank you all for those responses. I welcome everyone to add to the chat your own summaries and takeaways from this discussion, whether it's a phrase or a word that you took away. A quick summary from us, from our reflections, is that it's really helpful to identify an RTSS champion to really support the faculty education or your colleagues' education, but also to ensure that there's that shared language among colleagues. It's important to engage faculty in those collaborative meetings and hold those meetings frequently, and integrate assignments, learning modules across multiple courses. It's great to develop opportunities for scaffolded learning. We talked a lot about opportunities for scaffolding within and across courses and fieldwork education. And then we've mentioned before, it's in the chat, to utilize the RTSS networking group and curriculum task force resources. So there's a group of us who are working on this, and we support each other and we bounce ideas off of each other, and we're here to share these resources with you. And we did want to share some resources with you today. We have a QR code here. I will pause for a moment if you want to take a quick screenshot of these QR codes. That will take you directly to our host page on ACRM for our networking group. And it looks like, and Susan also added it to the chat. So thank you, Susan. And I'm going to end here and open up a resource that we will be sharing on the ACRM webinar page. But if you would like it sooner, please put your email in the chat if you would like this handout of RTSS resources. And it just includes some sample assignments that have been used in some of our courses, as well as some educational tools for clinical practice. So again, it will be up on the ACRM webinar page in about a week. But if you would like it sooner, please add your email to the chat and we will email it to you directly. And from there, it's overtime. I apologize, we're 2 minutes over. If you do have questions, we're happy to answer any questions. But thank you all for joining us, for attending. I hope you were able to learn from each other and get some little nuggets of information and helpful resources from everyone. And I can here are email addresses, but I'll also just show you this resource of sample assignments. Some tables that have been utilized that can easily be adopted into your programs. A preliminary assignment, just so you identify ingredients and targets. And then educational tools for practice, for treatment planning specifically. All right, I will open it up to anyone else who has any other comments. If not, thank you again for joining us. Apologies for running 3 minutes over. And enjoy the rest of your day or night.
Great talk. Good night.
Thanks, Jared. You can stay on if people have questions. And Susan, we could probably end the recording